the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. This week, we continue our conversation with Dr. Robert Baranello, Strategies in Interventional Pain Management. I'm mostly basing today's podcast on a presentation you gave in Tennessee, the pain conference in 2023, Neuromodulation, a tool for functional restoration and pain relief. You had gone through some case studies. You talked about one earlier in the podcast about the phantom pain. How about the case study you had, somebody that had the post-laminectomy syndrome? Because I think that's got to be one of the more common ones that you would see and do this with. So can you please talk about that case study?
The number of patients that I've seen now, finishing up my first year as an attending now, has just grown and grown and grown. But the patient that I mentioned in this talk was a patient who I met in fellowship and had the pleasure to take care of as a part of my longitudinal care clinic. So really was able to get to know them and see how they progressed through their previous failure of some of their more conservative measures up to trial and then implant. This was a 70-year-old lady who really had some ongoing, essentially radicular pain after having had this pretty big back surgery. She actually had 2 revisions, started with 4-5 interbody fusion in 2016, and then wound up getting revised into a 2-4 fusion. She just had some ongoing back pain that radiated into her hips and down into her knees. It seemed like L4 radiculopathy on both sides. She was on pretty high doses of gabapentin, taking Tylenol around the clock. We were trying compounded neuropathic cream that we were using a local compound pharmacy for, anti-inflammatory. We were really just trying everything under the sun for her. She had failed physical therapy and just came to us for, what those next steps might be. And so when I see somebody like that in clinic now, again, the options are doing what you're doing now. Maybe it'd be worth trying an epidural steroid injection. As we've had surgery, some of those injections can increase in risk as there's scar tissue, et cetera. But again, generally maximizing our conservative efforts as much as possible. And so again, when she presented to us, she had already gone through all of that. So we pretty much chalked this up to post-laminectomy pain syndrome. I think we had discussed before the podcast, it was sort of not nicely referred to as failed back surgery syndrome in the past. And I think it's unfair to have called it that for as long as we did, only because it's true. Like I mentioned earlier, it's not necessarily a failed back surgery syndrome. Sometimes these back surgeries, like in this patient, it is a perfect example. It worked for her. She had that L4-5 interbody fusion. She had virtually no pain for 4 or 5 years, but then wound up having to have a revision after that. And so we've now sort of changed the nomenclature a little bit to more post-laminectomy pain syndrome. But yeah, so, when we saw her, we landed on a device manufacturer that she had a family friend who had a great deal of success with. I would say the majority of people who do this type of work in the interventional pain management space would be able to accommodate any of the device manufacturers if patients have specific requests. So she had a specific device that she wanted to use. She had done her own research about it. We talked, of course, about risks, benefits, and alternatives, and she wound up doing incredibly well with the trial. She had 80-90% pain relief of her leg pain. Even some of her back pain improved. She stated that she got probably the best night's sleep that she's had in 2 or 3 years. She was walking for longer distances and standing for longer periods of time. We relatively quickly moved on to implant, and as far as I know, she's continued to do really, really well. It's cases like that generally, I think it just keeps us motivated about the technology. And it's hard to put exact numbers on it without looking at the literature, but I want to say it's probably somewhere between 70 to 80% of patients that we trial and implant get greater than 50% pain relief. And then even within that subset, I would say somewhere in that 50% range probably getting somewhere in the 80-90% plus pain relief. So again, it's as far as the spinal cord stimulation for post-laminectomy, that is far and away the biggest cohort of patients that we've studied for this therapy, continue to do well, and the evidence continues to be promising moving forward.
Dr. Baranello, what take-home points would you offer our listeners regarding neuromodulation for pain relief?
Yeah, we really kind of focused on spinal cord stimulation a lot today. I would say, one of the big take-home points is that this is an ever-growing field. The technology is only getting better. I think the future is bright for a lot of different neuromodulation strategies. I'm particularly excited about the peripheral nerve stimulation space. I have a lot of patients with non-surgical shoulder pain, post-operative, post-TKA pain, obviously peripheral neuropathies such as perineal neuropathies after knee replacement surgery. The list goes on and on. So the field, the growing number of patients who I think could benefit from some of these treatment paradigms is just growing exponentially. And so that, in addition to, I just think that the technology is just so exciting. The other thing to stress too is that for the most part, they're quite minimally invasive procedures. The risks involved in these procedures, although, like I mentioned, maybe a little bit more risky than some of the, simple epidural steroid injections that we do, but as it relates to surgery, is quite minimally invasive and is a great alternative to more invasive surgical procedures. I think the other thing that we touched on again is that, this is evidence-based, essentially hijacking of our own neural anatomy and our own neurophysiology. Again, we've known about this physiology since the 60s, and being able to essentially use our own physiology to almost outsmart our spinal cord and just sort of help sort of quiet down some of the constant painful signals that are being sent and received up and down that interstate that is our spinal cord every second of every day, is a really interesting treatment paradigm. And as I mentioned before, I think the number one take home for this whole space is that it's truly about accurate diagnosis. If you have the diagnosis right and you have the right patient selection, there's almost no way that your patients are not going to do exceedingly well with many of these strategies. There's never 100%, there's never always a home run, but accurate diagnosis is absolutely the cornerstone for this.
All right, neuromodulation and treatment for folks with some different problems that have been difficult to treat in the past. Dr. Baranello, thank you for being on our podcast, and good luck with that career.
Thank you so much for having me. It was a pleasure.
Thank you for joining the orthoPAC podcast. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.